Hi, my name is Mike Avila, and today we will be talking about basic transthoracic echocardiography, including the imaging windows and various pathologies. At the end, we will also talk about IVC measurements. The probe of choice for this examination is the cardiac probe, aka the phased array probe. This probe is great for fitting in between the rib spaces. If your machine does not have this probe, the curvilinear probe can be used, but really the preferred probe is the phased array probe. First, we need to talk about probe positioning. You will use the standard mode where the indicator is on the left of the screen for most scans that are non-cardiac. In this convention, the probe marker will either be to the patient's right side or to the patient's head. To get a cross-section of the heart, however, you need to imagine the heart as an upside-down cone. In standard mode, a cross-sectional view or short axis view of the heart will have the probe marker pointing to the patient's right hip and in long axis view to the patient's left hip. As an example, this is a parasternal long axis view of the heart. We are in standard mode, shown by the red arrow on the left of the screen. The probe marker on the body is facing to the patient's left hip. Contrast standard mode with cardiac mode. Notice the indicator is on the right of the screen, shown by the red arrow. In this view, again, imagining the heart as an upside-down cone, the long axis view will have the probe indicator pointing to the patient's right shoulder and in short axis orientation to the patient's left shoulder. This is opposite of standard mode, but so is the indicator on the screen opposite of standard mode. Therefore, the image acquired will be the same. Basically, if you flip the indicator, then you need to also flip the probe. This is a parasternal long axis view of the heart. Probe marker is facing to the patient's right shoulder, and we are in cardiac mode because the indicator on the screen is on the right side. Remember that the left ventricle should always be on the left of the screen for parasternal long axis. We will talk about that again. So here the image looks different. It is actually flipped. Remember when I said that the LV should be on the left of the screen? Well, here it's on the right. Why is this image flipped? First, see that the indicator on the screen is on the right, which tells you that you are in cardiac mode. Then, see where the probe marker is facing, and in this case, it is facing down to the patient's left hip, the orientation in standard mode, not cardiac mode. Remember, in cardiac mode for parasternal long axis, probe indicator should point to the right shoulder. This image also looks different. Again, it is flipped. Why is it flipped? First, see that the indicator on the screen is on the left, which tells you that you are in standard mode. Then see where the probe marker is facing, and in this case, it is facing to the patient's right shoulder, the orientation in cardiac mode, not standard mode. Remember, in standard mode, probe indicator should point to the left hip. So, to summarize, in cardiac mode, the indicator on the screen should be on the right side, and the probe marker should be facing the right shoulder. The LV should be on the left of the screen. Don't worry, there's an easy way to remember that, which we'll get to in a moment. In case you got lost, here's another summary when troubleshooting your image. First, check the screen for the indicator position. For parasternal long axis, make sure the probe is either pointing to the right shoulder in cardiac mode or left hip, standard mode. Also, make sure the LV is on the left of the screen for parasternal long axis. If you do the previous two and are still unsatisfied with the image, it may help to ask the patient to assume a left lateral decubitus position. This brings the heart forward and closer to the chest surface, which could help in acquiring your image. Have them lay on their left side. It may help to ask the patient to place his or her arm above the head. Now, we will talk about obtaining the cardiac views. You can practice your echo skills by developing a systematic protocol. A suggested approach can begin with the parasternal long axis view, rotate the probe 90 degrees for short axis, move on down to the apical forechamber, and then finish up with the subxiphoid window. Let's start with the parasternal long axis view. Start out in cardiac mode. The indicator should be on the right of the screen, and then the probe indicator on the patient's body should be facing the right shoulder. Start by placing the probe at the nipple line or fourth intercostal space, or in women, the inframammary line, right next to the sternum. Keep the probe perpendicular to the skin and hug the sternum as you go up and down the chest, searching for the best window. So I told you I would give you an easy way to remember the parasternal long axis view. You can remember it by the 3 L's to success. The parasternal long axis should have the left ventricle on the left side of the screen. So for a visual, here's what we're looking at. For the parasternal long axis view, make sure the left ventricle is on the left of the screen. Before we go identifying what we see on the image, it may be helpful to see a schematic representation on the ultrasound image. Toward the top of the screen, we will see the right ventricle, with the left ventricle beneath or deeper to it, and the interventricular septum in between. In the left ventricle, you can see the mitral valve and sometimes the papillary muscles. To the right of the mitral valves, you will see the left atrium. In this image, you can also see the aortic valves and the aortic outflow tract. Going back to the ultrasound image, if we again imagine the heart as a cone, the apex is at the upper left of the screen, with the base towards the lower right. Anteriorly is at the top of the screen, which makes sense because that is where you physically have the probe, on the chest. And deeper or towards the bottom of the image is the posterior portion of the heart. The items to identify in the parasternal long axis view are the left ventricle, the right ventricle, the aortic valve and the mitral valve, the left atrium, the interventricular septum, the descending aorta, which will be important for distinguishing between a pericardial effusion and a pleural effusion. We'll talk about that later. The aortic outflow tract, and the pericardium. The parasternal long axis view is great for estimating ejection fraction. There are a few studies that show that eyeballing the ejection fraction by looking at the squeeze of the heart and how closely the anterior mitral valve leaflet gets to the interventricular septum is a good estimate of the gold standard cardiology method of evaluating the EF. Additionally, it is much faster and can easily be done in the emergency setting. In this ultrasound image, you can see that the anterior mitral valve leaflet is slapping up against the interventricular septum. You can also see that there is good squeeze of the left ventricle and that the ventricular walls are almost touching with each contraction. This is indicative of a normal ejection fraction of greater than 50%. In this ultrasound image, the anterior mitral valve leaflet does not quite make it to the interventricular septum. Additionally, the squeeze of the ventricles just isn't as good as the last image. This EF is consistent with moderately depressed at 30 to 50%. How do we know it is not severely depressed? Look at the next image. In this image, there's very little motion of the mitral valve leaflets and hardly any squeeze of the ventricles at all. This is a sick heart with an ejection fraction of probably less than 30. If you want to quantitatively measure the ejection fraction and not exactly eyeball it, you can do so using EPSS, or E-point septal separation. This is a heart in the parasternal long axis view. If we want to use EPSS, we just throw down an M-mode spike at the tip of the anterior mitral valve leaflet. You can freeze the image and this is what you will see. The thicker white line represents the interventricular septum, and the squiggly wavy lines beneath that represents the motion of the anterior mitral valve leaflet. I don't know if you noticed, but the anterior mitral valve leaflet slaps twice on the interventricular septum in a normal heart. The E represents the passive filling of the ventricles, and A represents the atrial contraction. The distance between the IVS and the squiggly lines show just how close the anterior mitral valve leaflet gets to the interventricular septum. A distance of less than 7 millimeters is considered normal, and greater than 10 is considered LV dysfunction or reduced EF. 7 to 10 is sort of a gray area and needs to be taken into context. Notice, this distance is greater than 10 millimeters and is consistent with CHF. This is another example of reduced ejection fraction. CHF is not the only way that your patient can end up with a reduced EF. If your patient has aortic regurgitation, the backflow of blood will inhibit the anterior mitral valve leaflet from opening fully. This will make your EPSS larger even though there is no CHF. Or, if your patient has mitral stenosis, the poor excursion of the mitral valve leaflets will give you a large EPSS, falsely predicting cardiac ejection fraction. Now, I mentioned earlier that the descending aorta is important for distinguishing between a pericardial effusion and a pleural effusion. You can see in this image that this patient has a pericardial effusion because the fluid is within the pericardium, anterior to the descending aorta, shown by the bottom arrow. In this echo, you can see that the effusion is posterior to the pericardium and posterior to the descending aorta. This is actually a pleural effusion. We can't talk about pericardial effusion without talking about pericardial tamponade. Traditionally, the diagnosis of tamponade is made when you have diastolic collapse of the ventricle with clinical symptoms of hypoperfusion, such as hypotension, tachycardia, syncope, shortness of breath, chest pain, etc. What's happening is the pressure of the effusion is great enough to impair filling of the RV. Blood in equals blood out, so there will also be impaired filling of the LV. You can tell that there is diastolic collapse of the RV because it happens when the mitral valves are open. Right ventricular strain can be assessed in this view as well. Strain can be due to any acute event, usually a PE, that causes sudden pulmonary hypertension, causing resistance to the outward flow of the RV. This can cause the RV to enlarge. Now we're going to talk about the parasternal short axis. From the parasternal long axis view, rotate the probe 90 degrees clockwise towards the patient's left shoulder. Then fan towards the apex and up towards the base. Fanning up towards the base of the heart to the patient's head will get you more of the mitral valve, even the aortic valve in view. In this image, we are more inferior or towards the apex in the mid-papillary view. The circle in the middle is the left ventricle. On the other side of the IVS is the right ventricle. The arrows are pointing to the papillary muscles and the mitral valve. Fanning superior to the patient's head, you can see the mitral valve leaflets and the fish mouth view. Fanning even more superiorly, and you can see the aortic valve, called the Mercedes-Benz sign. Here's a schematic that will help identify the images in the parasternal long axis view, with the aortic valve in view. Most anteriorly is the right ventricle, with the RA feeding through the tricuspid valve. The tricuspid aortic valve is right in the middle. The left atrium is the deepest structure, feeding down into the screen out of plane of the probe. The LA is the deepest structure. So in review, more inferiorly or towards the apex is the mid-papillary view. Fanning up towards the head, you can see the fish-mouthed mitral valve. Most superiorly, you can begin to see the aortic valve. You can also assess for right ventricular strain in the parasternal short axis view. Here we see an enlarged RV and septal bowing, showing something called the D sign, where the pressure of the right ventricle is great enough during systole to actually cause the IVS to bend in towards the LV. Here's another image demonstrating the D sign. Now, we will talk about the apical four-chamber view. Make sure the probe indicator is pointing towards the patient's left axilla, and from the parasternal short axis view, slide down towards the apex until you see the chamber size getting smaller and smaller. Then, when you get to the apex, or when you see the chamber size getting smaller, fan up towards the patient's head. The probe at this point should be at the point of maximal impulse. The bottom right image displays the LA and the LV on the right of the screen, and the RV and the RA are on the left of the screen. As a general rule, taking the ventricles as one, the LV should take up about 2/3 of the total, and the RV 1/3 of the total. Consider PE or another acute event causing pulmonary hypertension if the RV is greater than the size of the LV. You can also assess for pericardial effusion in this view, as shown in the image at the top left. The fourth and final window of transthoracic echocardiography is the subxiphoid view. With the patient's knees bent, place the probe in the subxiphoid region. Make sure the indicator on the probe still points to the patient's left side. Assume an overhand grip on the probe. This will help you get more level and parallel with the skin, and will allow you to visualize the heart. Start on the patient's right. Locate the liver, and sweep to the patient's left, using the liver as an acoustic window. Basically, acoustic window just means using an organ that doesn't contain gas and allows sound waves to travel through. In the subxiphoid region, bowel gas can sometimes mess up your image, so using the liver as an acoustic window will help avoid this. You can have the patient take a deep breath to help bring the heart into view. So here, the liver is being used as an acoustic window. Remember, the RV is closest thing to the liver. In this view, you can see the LV, the LA, the RV, the RA, mitral valve and tricuspid valve, and the pericardium. This is a video clip of the same thing. Up here, you can see the liver, and right next to the liver, you see the RV. The subxiphoid view is pretty good for seeing a pericardial effusion. Here's another image of it. Remember that the traditional definition of pericardial tamponade is RV collapse with symptoms of hypoperfusion. Here in these images, we see a pericardial effusion, and in the image to the right, we see RV compression and collapse. This is a clip of cardiac standstill. Seems obvious, like why do we need to ultrasound that? But if you have a patient without a pulse, it helps to know that this isn't because of an arrhythmia, but instead because the heart isn't actually pumping. If it was an arrhythmia, you would see motion of the heart. Even though we talked about the 4 views of the heart, it would be prudent to also talk about the IVC, as this can help you gather more information that is very important about the patient's fluid status. In a nutshell, IVC measurements are important because they help guide fluid management. The respiratory cycles correlate with changes in IVC diameter in someone that can receive fluid, giving estimates of CVP. During deep inspiration, the diameter gets smaller, and during expiration, the diameter gets larger. We will get into this a little bit more in a few slides, but if the diameter does not change and remains open, remains dilated, this is a suspicion that the patient is pretty overfilled with fluid. The caval index is the percent collapsibility of the IVC throughout the respiratory cycle and is considered a predictor of preload reserve, or in other words, a predictor of how much fluid the patient can receive before you run the risk of pleural edema or effusion. Let's talk about how to obtain the correct image of the IVC. Start in the subcostal region. The collapsibility is measured by obtaining a long axis view of the IVC. Aim towards the head, which would be over here, until you see the IVC entering the RA right here. Changes in size throughout the respiratory cycle are identified with the machine in M mode. Measure the diameter 2 to 3 centimeters distal to the confluence of the hepatic vein and the IVC. So here's the hepatic vein and here's the IVC. The caval index is measured by taking the maximum IVC diameter during expiration and subtracting the minimum diameter of the IVC during inspiration from that, then dividing all of that by the maximum IVC diameter. This table was taken from acep.org and shows the correlations between the IVC size and the CVP. Small diameters with greater than 50% caval index correlates with a relatively low CVP compared to a dilated IVC with little to no change in the caval index, which correlates with a high CVP. In the first case, probably the patient can receive fluid, whereas the second case probably should not receive as much fluid. All right, so that was a lot. We talked about the cardiac views forming a protocol that you go through each time so that you don't miss anything. Start in the parasternal long axis view, rotate 90 degrees to the parasternal short axis view, go down to the apex for the apical four-chamber view, then, assuming an overhand approach, go to the subxiphoid view. We talked about troubleshooting your image. First, check the screen indicator, then check the probe positioning. Then if that doesn't work, put the patient in a left lateral decubitus if the patient is able to do so. To remember the parasternal long axis view, remember the 3 L's to success. The parasternal long axis view should have the LV on the left side of the screen. We talked about ejection fraction and how that can be a predictor of the patient's cardiac status, whether it's a strong functioning heart or whether it's a poor functioning heart. You can do that qualitatively by just looking at it, which takes little to no time, or you can quantitatively do it by using EPSS. We talked about pericardial effusion and how that's different from pericardial tamponade. We talked about right ventricular strain and how a pulmonary embolism or other cause of acute pulmonary hypertension can cause the right ventricle to enlarge. And we also talked about IVC measurements. We talked about the caval index and how that can be a predictor of the fluid status of the patient. Here are the references that I used, and that is it. I hope you enjoyed that. I hope you learned something. Have a great day.